Hi, my name is Sanduni Silva, and today I will be discussing clinical psychology and anger mismanagement in adolescents. So clinical psychology, what is a clinical psychologist? A clinical psychologist is involved with the assessment and treatment of mental health conditions. So they use evidence-based practice to assess and treat mental health conditions. So that's a pretty key distinguishing factor from other areas of psychology, the assessment and treatment part in relation to mental illnesses. So a counselling psychologist may not work with clients who have quite severe mental health conditions. They may not diagnose mental health conditions as well, whereas a clinical psychologist would. So they can work in a vast area of employment settings, including medical clinics, hospitals, and education institutions as well, and also in the private setting. So adolescent anger mismanagement. So anger in itself is not a mental health condition at all. It's a normal human emotion. When it's mismanaged, it can result in a lack of, regulation for the adolescent of their anger. It can result in aggression. Aggression is the behavioral expression of anger, whereas anger is kind of the emotional experience of anger. So they're quite different things. So the mismanagement is when the anger itself sort of causes a problem for either the young person or people around them. This could be, feelings of regret and guilt within the young person, and it could be being exposed to violence and aggression for other people. So that's kind of when anger, becomes problematic and is mismanaged. The etiology of anger in adolescence, there's a vast array of different reasons and causes of why anger can manifest in an adolescent. So I'm just going to cover these three key ones. So family, so modeling from family members, including parents or siblings, observing the way family members respond to conflict or are aggressive or angry themselves can result in a young person being influenced unconsciously or consciously by that behavior. This was kind of reiterated in the study by Avci and Gu-Cray, 2010. They compared the families of violent and non-violent adolescents and found that in the violent adolescents, their families displayed greater levels of anger, poorer communication and poorer emotional literacy, and more delinquent behaviors and substance use compared to the families of non-violent adolescents. This study did have quite a low sample size, which does limit the generalizability, but overall it does indicate that family can have a big influence on the way anger is experienced in a young person. This is also the case with friends. So particularly in the developmental stage adolescent is in, they tend to be develop more autonomy and self-identity, and that can be really informed by their peer influences. So Mastery and Bradley 2008 supported the, argument that negative peer influences can increase levels of anger in adolescents. They found that delinquent peer exposure was associated with an increased link of anger and violent offending in adolescents. So thirdly, media, particularly violent video games, which has gotten a lot of sort of attention in the literature over the last few years, can be linked to aggression and anger in adolescents as well. There's sort of mixed findings in this area. It's an emerging area of research, so more research is needed to get sort of a little bit more of an understanding of whether there is a real sort of causal link between video games and anger in adolescents. One study by Ferguson 2015, which was a meta-analysis, reviewed 101 studies and found that violent video game use was not actually linked to an increased aggression, which further highlights that while there's some studies that say that it does, some others say it doesn't. There's a lot of limitations within different studies. So more research is needed in that area to really know sort of whether the media does have sort of an influential factor. So as mentioned, clinical psychologists are involved with the assessment of mental health conditions. So assessment tools that clinical psychologists could use for anger is the STAXI-2 and the anger disorder scale. These can be used in research or clinical settings. The STAXI-2 was developed by Spielberger et al. In 1999. and it measures the state and trait levels of anger. The anger disorder scale was developed by Di Giuseppe and Tafrate 2004 and consists of 5 domains, or measures 5 domains of anger, which includes the provocation, arousal, cognitions, motives, and behaviors around anger. So the ADS actually measures only the trait levels of anger. It doesn't actually measure the state. It doesn't take into consideration, I guess, the changes of how anger can be expressed or experienced in an individual. So that's one limitation to the ADS. The STAXI-2 tends to be used more commonly, particularly in research settings. So these assessment tools, while useful, they actually can't be used to diagnose anger by a clinical psychologist, to diagnose any anger disorders. And that's because anger disorders are not recognized in the DSM as, I guess, a mental illness. Anger is often seen as a symptom of a diagnosable mental health condition, but not sort of a condition in itself. That can often cause some issues in the treatment of anger. It can often be, I guess, missed because it's seen as a secondary symptom as opposed to a primary concern. So some authors have kind of indicated that there should be, I guess, diagnosable disorders in the DSM for anger. This was suggested by Eckhart and Diefenbacher, 1995. They suggested 5 possible, I guess, categories of anger disorders with specific criteria which could be used and could be included in the DSM. While that's kind of useful in thinking about it and developing that proposition for the DSM, as a clinical psychologist, given they use evidence-based practice, those suggested criteria cannot be used in a clinical setting sort of directly to diagnose an anger disorder because it's not recognized yet in the evidence or the DSM as a diagnosed condition. So clinical treatments to anger. So cognitive behavioral therapy has the most vast amount of research supporting its efficacy in treating anger. There's several meta-analyses to support this. So Hoogster et al. 2014 investigated the efficacy of individual CBT therapy in severe aggressive behaviors in adolescents and found that it was effective in reducing aggressive behaviors and anger in adolescent populations. However, one limitation to this was that there was only 6 studies used and 4 of them had a weak research design. So another meta-analysis which used more studies was done by Suchodolsky, Casanova, and Gorman 2004. They used 21 published studies and 19 unpublished studies and found also that CBT was an effective intervention in reducing anger in both adolescents and children. So that just shows that there's a lot of meta-analyses, a lot of studies supporting CBT in reducing anger in adolescent populations. So other interventions which have some evidence to support them include mindfulness-based treatments and relaxation techniques. So mindfulness-based treatments have really only been researched thoroughly in the last sort of 20 years. So it's still a new area. And there has been some sort of initial research to suggest that it might be effective, including a study by Singh et al. 2011, which found that mindfulness treatments allowed anger to be controlled better among autistic adolescents. So this study actually only had 3 participants, so it's very low sample size, which limits its generalizability. But even after a 4-year follow-up, all 3 of the participants showed increased ability to control their anger. So it's a promising area of research at the moment, but does require some more evidence to support its efficacy. Relaxation techniques which are found to be effective in some studies include progressive muscle relaxation, imagery and visualization, deep breathing techniques in terms of the relaxation techniques. So some obstacles to treatment include factors within the client, such as their readiness. So issues such as mental health conditions and substance abuse can influence a client's readiness to engage in therapy, also their attitudes and beliefs. So beliefs such as therapy won't work, or their anger is justified, or blaming of others can hinder their ability to engage and also benefit from therapy. Also the setting as well. So often it could be hospitals or even prisons where anger management is delivered to a young person, and that environment may not be conducive for effective therapy as well, compared to, say, a community setting, and there has been some research to support that community settings tend to be more effective in that regard. Also the therapist or therapy factors as well. So there's a lot of research supporting the importance of a strong therapeutic alliance in the efficacy of treatment. So if a young person doesn't connect, click, or trust their therapist, then they're less likely to experience success in therapy as well. So a sample case study to sum up a clinical psychologist's role in treating anger mismanagement can be seen here. So let's take the case of Sam, a 17-year-old male. He's taken to counselling to see a clinical psychologist by his parents. He's been aggressive and violent towards peers and family, a lot of fights, throwing objects, raising his voice, gets angry at pretty small things, and he's been suspended from school. He's lost a lot of friends and experiences a lot of shame and guilt and regret around his anger. He's consenting to treatment, and how would I treat him as a clinical psychologist? So firstly, I will have the first session by talking about privacy and confidentiality and really assessing the presenting problem. That can be done using the assessment tools discussed earlier, such as STAXI2, really to get a thorough gauge of the sort of level of anger that Sam is displaying. I'll also get a background of, say, his family, his history, do some goal setting, and also focus on rapport building for the first session. The second session, I would commence cognitive behavioral therapy as the therapeutic intervention, given it has the largest evidence base to support it. This generally would involve sort of psycho-ed around what cognitive behavioral therapy is, perhaps the next session, session 3, introducing concepts such as self-talk and unhelpful thinking styles, using examples from Sam's life, so his own triggers, to identify his own unhelpful thinking styles and negative automatic thoughts, prescribing homework to help him practice doing that identification stuff himself as well. Session 4, go over the homework, but start the cognitive restructuring process, which involves challenging some of those unhelpful thinking styles and also negative automatic thoughts through using evidence and practicing that with him in session and giving him homework to continue that at home as well. Session 5, I would work on continuing on to practice those CBT techniques of identifying negative automatic thoughts and cognitive restructuring, and perhaps practicing this in session by using a visualization task to dysregulate Sam, to get him kind of feeling a bit agitated and angry, and then practicing those CBT techniques in session with him to get him to recognize how to do that himself. Session 6, recap on previous learning, reassess the goals. If they're met, you could close. If not, continue on with the CBT strategies already introduced until Sam really kind of identifies and is able to integrate that into his day-to-day himself. These are my references. Thank you so much for listening to my presentation.